Good afternoon, everybody. Without further delay, we'll start this session. Uh, Dr. Anshu Rohtangi needs no introduction. He is a good friend of mine and is an extremely reputed neurologist, well known in India and abroad. His interests, he's with Gangaram Hospital. His interests in multiple sclerosis is well known, and he's going to deliver a talk on Ocrevus, which we know is the new game in the corner. Thank you, Dr. Anshu.
Thank you, Dr. JD, for a very kind introduction. Good afternoon, everybody. And I think after lunch, I think everybody will be a little sleepy, but I will try and wake you up and see if we can deliver the message that I want to send across. So we are going to talk about Ocrevus. So as the name of my topic suggests, it's a revolution, Ocrevus or Ocrevus revolution. And this is Ocrevus has changed the way that we treat MS not only in the West but also now in India. So it is really going to be the game changer in the treatment of multiple sclerosis, especially in primary progressive multiple sclerosis, because previously there is no treatment which is available even now, and this is the only approved treatment for primary progressive MS. So Ocrevus is basically indicated for two indication, and that is first is relapsing remitting MS, and second is primary progressive MS. So, so basically, all of us know a lot about CD20 cells. We have all of us have used rituximab for a number of years, and we all know that Ocrevus is one level above rituximab because it's a humanized monoclonal antibody which basically acts on the CD20 cells. So basically, Ocrevus it goes and binds to the epitope in the extracellular domain of CD20, and by different mechanisms, it brings about the depletion of CD20 cells, whether it's a complement-dependent cytotoxicity, antibody-dependent cellular phagocytosis, or even the apoptotic pathways. So by different mechanisms, ocrelizumab brings about the death of these CD20 cells. So the kind of literature that we're talking about Ocrevus, the number of trials are really too many. So I won't be going through all of these trials because it will take the entire day to finish all of them. So the main trial that we're going to talk about today is the landmark trial of multiple in relapsing remitting MS, and that is Opera 1 and Opera 2. And these two trials are almost similar. Actually, it's an FDA regulation to have two similar running trials before a drug is approved in the US for multiple sclerosis. And then you have the Ontario trial, which is the trial of ocrelizumab in primary progressive MS. And then you have the OLERA trial, which looked on the long-term extension phase of both of these trials, both in relapsing remitting MS as well as in primary progressive MS. And of course, you have then the number of trials like Ensemble Plus, which calls about a shorter IV infusion. And now we have a subcutaneous form of Ocrevus. And I think this is a trial which really looked at the comparison of a subcutaneous Ocrevus versus an IV form. And then you have the CHIMES in underrepresented communities, and then you have the Operata 1 and 2 in child and adolescents. And so there have been a huge number of these trials. I'll just not bore you with all that data. So I'll just move on to the most important landmark trial which led to the approval of Ocrevus, and that was the Opera 1 and Opera 2. So what was these Opera 1 and Opera 2? So they were two identical studies, and they took patients of RRMS, and these patients were basically compared with interferon beta 1A, that is Ribif, 44 micrograms subcutaneous 3 times a week. So basically, there were two groups, and one group was receiving the interferon beta, and the other group was using ocrelizumab 600 mg every 24 weeks. And then you have to do MR at different times: 2, 24, 48, and 72, 96 weeks. So these there were two groups of patients. So one were randomized to either of these two groups. So patients who were able to complete this Opera 1 and 2 were taken into an open label phase where they were given 600 mg every 24 weeks. So the primary endpoint, as in all MS trial, is annualized relapse rate at 96 weeks. The secondary endpoint was the EDSS-based disability point, which looked at the time to onset to confirm disability progression. It also looked at a new criteria, which is confirmed disability improvement. Till now, most of the MS trials were talking about disability progression, How can we prevent disability progression? But this was one of the trials which looked at the confirmed disability improvement, and that talks about the confidence the investigators had in the product that it is going to produce improvement. And of course, the MR endpoints we all know: number of guide enhancing lesions, increasing T2 lesions, number of black holes, the change in brain volume lesion. And of course, then you have the functional endpoint, the MSFC scale, and the SF36. And of course, number of patients having NIDA by the week 96. So if we look at the Opera 1 and Opera pool trial, if we look, there was a 47% relapse reduction in relative risk. And there was a 40% reduction in relative risk of CDP, that is confirmed disability progression on EDSS. There was an improvement in 33% of patients. And all of these p-values were clinically significant. If we look at the MR criteria, even in the MR criteria, there was a marked improvement in the group which was taking Ocrevus versus a group which was taking interferon beta. Coming to the other study, that is the one in the primary progressive MS, because the need of the hour at that point of time when these studies came, and now even now, is that we do not have a very good drug for primary progressive MS. Still, Ocrevus came along, and then so we had this trial, which is the Oratoria trial. I'm going to talk about that. So what it looked was Oratoria. It basically looked at evaluate the efficacy and the safety of ocrelizumab in adult patient with primary progressive MS. So this was again a double-blind treatment phase, and the minimum five 24-week doses of total of 120 weeks were given of Ocrevus, and these were 600 mg, which was given in from first to sixth doses, and they were compared with a placebo. And so these patients had to take about 120 weeks of therapy, 5 cycle treatments. And eligible patients who finished could open into an open label phase. So, so what it basically this study looked as a composite disease point with a time to onset of 12-week CTP, and they looked at the secondary points like the time for 25 feet walk, again the brain volume T2 lesions, loss of brain volume, and it looked some exploratory markers like the 9-hole peg test or new enlarging T2 lesion. And what this study found was that in most of the criteria, whether it was a 12-week CDP or that is confirmed disability progression, both on 24 weeks and 12 weeks on EDSS, change in the time to take a 25 feet walk, the brain volume loss, the T2 lesions, most of these criteria were statistically significant except for the change in SF36 PCS from baseline to week 120. So from the basis of these positive results from the Oratoria trial, the drug Ocrevus was approved for use in primary progressive MS. So you can see in most of these factors, the drug was effective. So as far as efficacy was concerned, both the trials, the Opera 1 and Opera 2 and the Oratoria showed that the drug is effective both in RRMS as well as in PPMS. So now the next question was, is the drug safe? So they basically looked at the most common side effect that we see, not only in trial basis, but also in clinical practice, are the infusion-related reactions. The infusion-related reactions were much more with rituximab because it's a chimeric antibody. Whereas being a humanized monoclonal antibody, the incidence of acute infusion-related reaction or hypersensitive reactions are much less. Then, of course, because we are depleting B cells, there are chances of infection, especially serious infections, especially during the COVID-19 patients who were on Ocrevus or rituximab had a tough time. And of course, the depletion in immunoglobulin levels. And there was initially some potential risk of malignancy, especially breast cancer. I'm going to talk about that later. And a potential risk, of course, is PML, which is always there in these kind of patients. So looking at the safety data that we had from the Ocrevus trials, of course, I said the infusion-related actions are most common, but definitely much less than what you see in rituximab. The infections, of course, most common are the URIs, and no other opportunistic infection was seen in the trial phase, and it did not appear to affect the prior humoral immune response to vaccinations. So, as far as the malignancy is concerned, the risk of malignancy was low and similar between the ocrelizumab and the interferon group. And this is very important. Even in the long-term data, it was seen that it does not increase the risk of malignancy. And in the clinical trial, as of March 2022, there were no reported cases of PML. So basically, then they had this long-term data from both these studies, the Opera and the Ontario, and they basically looked at patients who were followed up both from RRMS and PPMS. So what they wanted to see is to see the long-term effect of occultism on disability accumulation, both in relapsing as well as in primary progressive MS. So these were the patients who were really followed up in these studies, and these were patients from both Opera 1, 2, and Oratorio studies. And so patients who were in Opera 1, 2, they had an EDSS which was 2.8 plus minus 1.3. The Oratorio patients were definitely more disabled with the EDSS ranging from 4.7 to plus minus 1.2. And if you look in this bar diagram, it is very, very clear that the annualized relapse rate decreased year on year from the pre-switch year to the year 10 in the interferon Ocrevus group switchers and was maintained at low levels in all the Ocrevus group. So patients who were on Ocrevus right from day one, they had a very low relapse rate compared to patients who were initially on interferon and then switched to Ocrevus. So if you look in the if you start the number ARR was much higher when we started initially, and as the end of 10 years, you can see the numbers have really gone down. So it's really effective in decreasing the annualized relapse rate in patients of Opera 1 and 2 were followed for a period of 10 years. And same way, if you look at the T1 GAD enhancing lesion, which is a surrogate marker of the disease activity in MS, it really shows that Ocrevus treatment led to almost a complete suppression of the MR activity in patients who were suffering from RRMS. And these patients were also seen when these patients from interferon beta 1 were switched to Ocrevus. The number of new enlarging T2 lesions would also lead to a complete suppression of MR activity even in these patients who are RMS. So not only annualized relapse rate, but the MR activity really reduced in these studies. Now coming to the disability occlusion, which was very important in patients with primary progressive MS, it was seen that over a period of 10 years, if you look, we started from 100, it's just gone down over a period of 10 years. Patients who were both from the Ocrevus group and the placebo Ocrevus group, the 10 years, people who were primary progressive MS, there was a 22% reduction in the risk of having composite disability worsening in patients who were Ocrevus earlier as compared to those who were delayed treatment. So delayed, if you start late in patients with primary aggressive MS, then the disability tends to accumulate. But if you start early, you would have less disability accumulation. And this is the same talking time to taking walking aid and time to wheelchair, both in RRMS as well as PPMS. The earlier you start, the better it is. So the dictum is hit early and hit hard because we are dealing with an autoimmune disease. So earlier and harder we hit, the better results we are going. And I think we should all learn. This is very, very important because we should all learn from our rheumatologic colleagues who are very, very aggressive in treating all autoimmune diseases. So we need to learn that. So starting Ocrevus 2 years earlier saves almost 10 years of disease progression in people who have got an RRMS. So the notable impact of a decade of Ocrevus therapy is in reducing disability accumulation really reinforces the treatment that we should treat whether we have a treating a patient of RRMS or a patient of primary progressive MS. We need to hit early and hit hard. I think if I'm able to get that message across, my job is done. Just a final word about the ensemble study. We looked at a low disability accumulation after 4 year therapy with Ocrevus in patients who were treatment naive and who were given early RRMS. It just reiterates the same point which I'm trying to make initially. So this study basically looked at the effect of Ocrevus as a first-line therapy on measures of disability progression in patients who were recently diagnosed. Because a lot of our colleagues say that this patient just started just started with RRMS. Why do you want to put him on Ocrevus? So this really brings about what I want to say. So it looked at 3 disability progression points. That is 24 weeks confirmed disability progression, 25 feet walk, and a 9-hole peg test. And these patients were given Ocrevus in the classical regime that we follow, the 300 mg 2 doses, 2 weeks apart, then 600 mg every 24 weeks. So they looked about 678 patients were taken in this study, and the qualifying event was a relapse. And what this basically showed that they have very high retention rate, almost 81%. And very, very few people withdrew because of the adverse effects. So after 4 years, almost 2/3 of the patient treated with first-line Ocrevus showed complete resolution of the disease activity. The majority of patients maintained stable or improving EDSS over a period of 4 years. And again, the time for 24 and 48-week confirmed disability progression and improvement were definitely, the numbers were really in favor of Ocrevus. Uh, the adverse event was again infusion-related reaction, nasopharyngitis, headaches, and of course, these were done in the COVID time, so there were incidents of some COVID pneumonia. So there were no new safety signals. So to conclude, the positive benefit risk profile of Ensemble really supports the use of Ocrevus as a first-line therapy, even in patients who were newly diagnosed RRMS. So to conclude, Ocrevus is the anti-CD20 monoclonal antibody with the most robust data set. So I really didn't show all the data, and you can see, I showed you the trial in beginning, and the data is very huge. And the early treatment extends the progression-free event window by almost 10 years in patients with RRMS, and 90% of RRMS patients did not require a walking stick, and 80% of PPMS did not require a wheelchair. So even as a first-line therapy, Ocrevus stands its place, and safety of Ocrevus is almost at par with other platform therapies. Thank you for a very patient listening.
Thank you, Dr. Anshu. That was wonderful. Uh, in the interest of time, 1 or 2 questions may be allowed. Any pressing questions? Otherwise, we end it here. Yes, Dr. Chan.
Yes.
Most of the neurologists in the country are using rituximab, as you know. So, in your experience and the way the drug is handled, the implication is that this we're going to use for 4 years at 6 monthly intervals.
No. So, you, JD, you are running so many trials yourself. So this is basically, the trial is only for 4 years. So now basically, so you have to basically continue the drug. You can't stop the drug. That is, even for rituximab and Ocrevus, you need to give the drug. So the what we are doing is, so I've been using Ocrevus for now almost 3 to 4 years now. So although it has come now, but I've been using for 3 to 4 years, and so we have had patients who have done really well with the drug. So what the regime we are following is that you give 300 mg dose now, 300 mg dose after 2 weeks, and then every 6 months, without doing the CD19 cell count or the CD20 cell count, you give 600 mg. So a 600 mg dose has to be given every 6 months. So this is a regime that has to be
No,
followed.
that we could gather. So what had happened was Neil Robertson was here from Wales, I think about 6 months ago, and he kind of implied in our conversation and the group meeting that we had that even in England, in Wales, at the tertiary center for all patients that are referred for MS, even for rituximab, they have a little cutoff for about 3 years. If patient has no activity for 3 years, they stop the drug.
I
And
think
wait and see how that
I think
goes.
that is wishful thinking. In fact, actually, in the extremes, I and Dr. JD Mukherjee, we had a very good debate on when to stop treatment. I think that's a whole huge topic. And right now, what the guidelines really say is that at least till the age of 55 years, you need to continue treatment, because after 55, immunosenescence comes in. That is a point of time that you can stop the treatment. But so one of these, I think it was a discom study, the discontinuation of MS. So it really shows that you have to continue treatment at least till 55. Even after that, the guidelines are not clear. It's a very gray area, and it has to be individualized. It is very easy to say that we can stop at 55, but I have had patients. Uh, Now we are not for Ocrevus, but even for rituximab, they have been on treatment for almost now more than 10 years, and we need to continue the treatment. We can't stop it. So I think the question is still unanswered. I think in UK the guideline may be different because of the financial resources may be limited. The NHS may have limited resources, but right now none of the American guidelines or the European guidelines say that we can discontinue treatment.
In fact, may I just add something?
Hmm.
I have been, and you must have also been seeing a lot of late onset MS. After 40 years, 50 years, first time MS is coming. This is something very new which I've been seeing lately. I don't know if the others. Any one last question, please, if there's any? I think that's okay. Thank you, Dr. Anshu.
Thank you. Thank you.